Good day, global citizens. Welcome to another episode of Dr. Fajembola'S Opinion. On today's episode, I have another researcher, another doctor, a female, who I'm glad to bring on board. Join me to welcome Dr. Sumayya Al-Mansur. Dr. Sumayya, how are you doing today?
I'm fine, thank you. And thank you for having me on your platform.
Thank you for accepting the invite. You know how we do, Dr. Sumayya. First of all, before we start discussing, we look at some tweets, but first let's give our audience your profile. Dr. Sumayya Al-Mansur is a medical doctor, public health educator, and doctoral student at the University of Maryland. Her expertise spans clinical practice, public health, and health communication. She works at the intersection of medicine and behavioral science, focusing on designing and implementing effective health communication strategies. Passionate about health education and impact, she bridges research and practice to improve health outcomes in underserved community. Beautiful profile, Dr. Sumayya.
Thank
Beautiful
you.
profile. I got 3 tweets in relation to today. We are looking at the National Health Insurance Scheme, and I'm so happy that you are the one on board, like it's a medical doctor on board to discuss the topic for today. And also, most especially because I have first-hand experience as someone who has used NHIS. So and I must confess, before I even go to the tweet, I must confess, when I was reading the paper, maybe because I had experience, or maybe because I worked as a doctor with NHIS patients, it was hard getting questions. Like, I was trying to simplify it, like other papers. I would get like questions in a way that when we finish discussing, you might not need to read the paper, you understand what the researcher is saying. But for yours, like, it's already simplified. So this is telling our audience ahead, please read the paper. Like, it's so easy, like it's so simplified. Like, I didn't find complex terms to say that, okay, let me say she should simplify this, or let me say she should discuss this. Like, it was lengthy a bit, but the use of words, it was very simple, very easy to understand. So I had to like put micro, okay, let me get something for her to be able to say on NHIS. Thank you so much for the paper.
Yeah.
The first tweet we're looking at is from Mazi Nathan on Twitter, on X, before Elon Musk arrests me for saying Twitter.
Yeah.
The first tweet from X is from Mazi Nathan, is having good health is such an underrated blessing. And in all you do, try and get on an NHIS plan. I know how much I've spent on medication alone in 1 month. The next tweet is from Capitano MD. He said, no matter the rainfall, whether heavy or mixed with thunder and brimstone, NHIS patients will always find a way to come to the hospital for, for their usual trial, fever, cough, and catarrh. I always see Capitano MD. I always see him complaining about NHIS, especially like he has a series of tweets on NHIS patients.
Okay.
The last tweet is from Ileiwan of Yenegua. He said Nigerians can now enroll for the National Health Insurance Scheme from home using their NIN. This initiative by President Tinubu's administration makes health coverage easier and more affordable. So it's good to see that the current administration in Nigeria is invested in the National Health Insurance Scheme. Kudos to the Ministry of Health for that. So Dr. Sumayya, as I said, I have experience using NHIS from a young age because my parents were civil servants and they subscribed to it, and it made our lives easier. I can say confidently that NHIS has reduced the morbidity and mortality rate of Nigerians significantly, even though like a large sum of Nigerians are not subscribed to health insurance. And what I know about the health insurance, because I grew up like using health insurance, I know it started around 2005. and NHIS as a social health insurance program was intended to provide health insurance to all Nigerians, irrespective of their income or employment status. That was the intention, irrespective of income or employment status. But let's see from the discussion if NHIS is achieving the mission and vision it started with. So, Dr. Mansur, I know you to be a medical doctor who has transitioned into public health, and many doctors are doing that, even me. But like you are transitioning, many doctors in the new age, the new doctors are not like going like upwards into the medical field. What is expected, like the norm. So, what shaped your decision as a pub to move from medicine to public health?
Okay, so thank you for that question. And I think, first of all, I'll say I didn't move from medicine. I'm still in medicine.
Okay.
Yeah, so I think we all trained and worked as clinicians. And one thing I think across most doctors, 90% is we truly loved the patient interaction. So we're sitting with someone, we're listening to their fears, we're reassuring them, we're trying to treat illnesses. So I think those moments actually give purpose. But then over time, for me, I began to notice that for every patient I treated, right, there were like dozens outside of the hospital who might never make it in to the hospital. So either because they couldn't afford it or because of distance kept them away or lack of access to even the hospital. So I think that particular realization pushed something in me because most of my practice was in the Northeast and there was a lot of Boko Haram. And also, I actually have like firsthand experience with underserved communities. So I wanted more than that one-on-one care. And so I tried to see if how can I influence the system, shape how people, even if they don't go to hospital in the first place, how can it be better? So I think the first role but most importantly, I still loved like the patient interaction. That was one thing I think that gave me a lot of purpose. So my first role in public health was as a HIV clinical mentor. And interestingly, I still kept my access to patients, but this time I wasn't just like seeing them myself. I was mentoring healthcare and providers, trying to strengthen systems, build capacity, and that made me to I found happiness. I think that was one of the best jobs I did. And that particular work had a lot of ripple effects. So instead of one patient, I was indirectly improving care for hundreds, maybe thousands, I don't know. So I think that was my turning point. I began to see medicine not just as like stethoscope and prescriptions and all that, but as part of like a larger puzzle, right? We're talking about policies, we're talking about education, prevention, equity. So it's all medicine, it's all public health. And public health gave me that platform. So I can ask, how do you prevent illness before it even starts in the first place? How are we designing systems where like the most poor in the market, in the farms, in the villages have a good chance of health like everyone else? So I think that's one of the main reasons why I transitioned. And I think another personal reason was I think I felt caged in the hospitals. Yes, so I just really wanted more. So I wanted to explore the structures and impact lives in outside the hospital walls. But kudos to our clinicians, they are doing excellent. We can't do without them, basically.
Yes, of course.
And I think that transition also continues today in my doctoral work, where I focus on health equity, digital health, and using like communication, health communication, basically to shift behaviors and also empower communities. So I hope in a short sentence that gives like my transition story.
Thank you so much for sharing your decision-making process with us. That's very inspiring. Actually, public health is a subset of medicine, and one funny thing is when I did public health in medical school, I didn't see myself doing public health or even investing my time in public
Oh,
health after
nice.
medical school. But you know, the say God plans and is the best planner. So that's one aspect of my career I'm really pushing for, and I'm glad more people are going into, more doctors are going into it, and I believe with this we'll be able to improve the health care, not just in the global north, but also the global south, where we need more hands-on. Dr. Sumayya, in the paper, I came across because we want, even though I emphasized earlier that your paper is so simplified, I came across universal healthcare mantra like consecutively, and I feel this is what someone who is outside healthcare, or even someone in healthcare, if they don't know it, they are not someone who want to get more knowledge, might not know what it is. What is the universal healthcare mantra?
Okay, so when we hear the universal health mantra, I'm sure it sounds abstract, but really, in simple terms, it's just a simple idea where healthcare is for all without financial hardship, as simple as that. So we want healthcare for everybody without financial hardship. So let's think of it like when your car breaks down, you have insurance that covers major costs. When, God forbid, it's the Nigerian in me, your house burns down. If you have insurance, your insurance covers that. So you're not starting from the scratch. But then most times you see that when it comes to our bodies, many of us are left like exposed. So universal health coverage mantra, and the mantra says no, healthcare should not depend on how rich you are, whether or your zip code or wherever you're staying should not affect that. So the mantra actually comes from WHO's principle of universal healthcare coverage, which means everyone, regardless of income, I think you mentioned that earlier, your location or your background should have access to quality health services, like quality health without suffering any financial hardship. So the main mantra is just about equity, access, affordability of healthcare, so that everybody should be able to go to the hospital, get treated. You don't have to sell your family land, you don't have to borrow money or drain the whole savings that you have. Because I think this is a very common, we've seen it either from our family members, from our communities. You see somebody is earning, let's say, 3,000, someone that's, let's say, that works in a market, earning 3,000 a day. So if maybe her daughter or her son has appendicitis, and then it costs 1,000, 150,000 or 200,000 without insurance, that bill can wipe away like years of savings. And that's the essence of the mantra, that health is a right for everyone and it's not a privilege. And just one sickness should not make you poor, basically. It should not make you financially unstable. So,
Thank you so much, Dr. Sumayya. Thank you for emphasizing that the mantra is about giving affordable healthcare for all and which is accessible. Also, going forward on the paper, in one of the previous episodes we have, when we invited guest researchers, we highlighted she highlighted, how healthcare is way cheaper in Uganda because she has worked in Uganda health system and Nigerian health system. She highlighted how healthcare is cheaper in Uganda than Nigeria because a lot of healthcare in Uganda is subsidized. So the out of pocket is very little. And even if you want to go further to get insurance, like then it's like nothing. I had situations where even referral hospitals in Uganda, you pay so like a token to get cesarean section done is even free. So in respect to the paper, I got that only 5% of Nigeria, which is very surprising, very shocking. Only 5% of Nigeria's population has health insurance, and the vast majority still pay for medical care out of their pockets. Dr. Sumayya, what factors contribute to this?
yeah. So I think when we're even throwing about numbers and we're saying in percentage, it doesn't show how bad it is. So when you say we're over 200 million Nigerians and only 5%, that's more than 190 million, if my math is right, are paying cash out of pocket, right? So you're talking about 200 million and 190 million. So you see,
Wow.
5% doesn't even do justice to that. So, and I think it's multifactorial. A lot of factors would. I think, first of all, I would say is awareness and education, because many Nigerians simply don't know what health insurance is. Because not even health, a lot of insurance, you'd see that people don't really access insurance, whether car, whether houses. We don't really do insurance that much. So sometimes I want to use the word like, because I have worked in health insurance clinic during my clinical practice, I think for 2 years. So I have had directs. So they see insurance as a scam. So you would ask people, seriously, you ask people that, let's say taxi drivers or just the common man, and they just see it as it's either those that thing that government workers are enrolled to, and it's not for people like us. So I think the first thing is awareness and education, and also because I think over 80% of Nigerians work informally. So not so many people are doing blue collar jobs. You have traders, you have farmers, people that do outside those that do formal jobs. So people like that, they fend for themselves. So they don't see the reason why to enroll in insurance, because there's already that perception that is for civil servants. Another thing is like the perception of costs. Because there are different premiums. There are ones as low as 12,000, 15,000, but people just feel because it has to do with the government, it has to do with civil servants, it is expensive, and people just are trying to survive. And I acknowledge that seriously, people are trying to survive, but there's also that cost perception. So you don't see it as a necessity. You already feel that it is expensive. So you don't want to access that because you're trying to survive. You're thinking about rent, food, and school fees. So health is always taken to the back burner because we don't prioritize health till it comes knocking on our doors. So another thing with I think for Nigerians is also trust issues. People are like, if I pay for insurance, will the hospital really treat me well? Or what if I don't get sick? So they are using my money to treat someone
Mhm.
else. So there's that trust that or maybe even past negative experiences can fuel the people being skeptic about accessing health insurance. Then I think this last point is one of the one reason why a lot of people don't access health insurance, even those that is accessible to them, people, civil servants, is bureaucracy, delay in claims, because and sometimes weak systems, the health insurance, poor monitoring, lack of accountability. So it discourages both the those that are enrolling, the enrollees, and also the providers. Because I have had a lot of experiences that people come, especially for investigations, and you need a code. And sometimes those codes take 2 days. So you go and come back, and then you need another investigation. So you see people doing trips to the hospital, and that it's cost intensive. So you'll be like, why not just I pay out of pocket and just get done with this? Because you're using a lot of your time. So I think this is the reality of most people. People don't actually even understand the importance of health insurance, and hopefully like with better trust building and making insurance enrollment automatic, which is very good with the NIN integration. So people will tend to do enroll better and be more educated. And I hope that we would move from that 5% and hopefully at least let's move to 30. Let's start with that.
Thank you so much, Dr. Sumayya, for shedding more light on why we have enrollment of NHIS in Nigeria. What is the difference? Because NHIS is what Nigerians know. And across the paper, I came across NHIA. What is the difference between NHIS and NHIA?
Okay. So I think let's roll back to NHIS, which is the first, you mentioned it was launched in 2005. And yes, and the main goal then was providing the social health insurance. And on paper, it looked good. But then in practice, as every other thing, there's no perfect system. It had some limitations. So the NHIS had restricted coverage. So mainly it served like federal government employees and a few organized private sector workers, people like all other private that could afford it. So they were part. So there's actually restricted coverage. And then NHIS was actually voluntary. So it was not mandatory. If you wanted to join, you could join. If you didn't, nothing happened. So that meant like few people signed up for it. And as I mentioned earlier, there was actually low trust and awareness. So that tiny coverage it showed that NHIS struggled. So you look at NHIS then as it was like a cooperative society in most companies. Like,
Exactly.
yes, it's like so it's useful for those inside, but there was no power to bring others outside. It didn't have any enforcement power. So state and private citizens could just ignore it. And sometimes even hospitals didn't take it seriously because the enrollment was poor. So they were not really bringing in money and people did not enroll. There were a lot of complaints of poor service and like limited provider options. So after I think a lot of back and forth and growth through the years from 2005, and there was during I think President Buhari's 2022 there was a shift from the NHIS. The difference was just the S and the A. So from the National Health Insurance Scheme to National Health Insurance Authority, right? And then what are the main differences? We're shifting from a scheme to an authority. So with NHIA as an authority, it had regulatory powers not just like the scheme where it was optional. So in the NHIA, there was mandatory health insurance. So under NHIA, every Nigerian is required to have health insurance. So there's a big shift from the optional to now it being compulsory. And another big shift was the state health insurance agencies. So NHI is still working with states to create their own insurance programs. I'm sure of states like Lagos, I think Kwara and Kaduna, they have their own agencies. So the states run the insurance at its local level, but still under the umbrella of NHIE. And another main shift from the NHIS to NHIA was that the NHIA now regulates the HMOs, which are the health maintenance organizations. And what do they do? So they're just like companies, they are the middlemen of health insurance, right? They are licensed by government. Now they are licensed by NHIA. Under NHIS, I think directly by the government. So now they manage the health plans because basically when you enroll in the health insurance, you don't go directly to NHIE. So instead, you pick an HMO, and that HMO is the one that connects you to the hospital, right? So those are some of the so another thing is funding the vulnerable. The NHIA and the law provides like a vulnerable group fund, which helps to cover Nigerians who are poor and cannot afford premiums. People
Beautiful.
like yes, people like children under 5, pregnant women, elderly, people with disabilities. So the extent to which that is used, I cannot say. But then that is what it's supposed to be. And as I said, there's no perfect system. It's just 2022 and there's growth and all that. So we're hoping that all these things get implemented. And so the main thing is NHIS was just like a voluntary gym membership. So you could join if you wanted, but most people didn't bother. So as a result, like a lot of people didn't enjoy the benefits. So with NHIA, it's like you're doing compulsory, you're making it a compulsory subject in secondary school, like physical. So
Mm.
it's not optional whether you want to do it or not. So everyone has to participate, and there are rules and enforcement. So the way you can't opt out of it, right? And that would make like the system stronger, and people would now have no other reason but to explore the opportunity of using NHI. So I hope that helps.
Thanks so much, Sumaya, for educating us on the difference between NHI and NHIS. Actually, when I read it from paper, I didn't understand it to the level at which you explained it. And that is why we are bringing guest researchers to explain from their perspective their publications. And it's interesting to know that the NHI is an upgraded version of the NHIS. And I believe I'm optimistic with the NHIA on board and with governments being serious about it, as we've seen from one of the tweets. The reduce mobility and mortality in Nigeria, which improve health system and which will also increase our lifespan as citizens. I'm optimistic.
Yeah.
Okay, Dr. Sumayya, with regards to the paper, what are 3 things you want Nigerians to know about NHIS? Like,
So I think the first thing is insurance is for everyone. So I think that's one myth. Like you don't have to be rich, you don't
Government
have
work.
to, yes, you don't have to be a civil servant. It's not just for government workers, farmers, traders, anybody can enroll. So insurance is for everyone. I think secondly is it's affordable protection. So for less than maybe a cost of two bags. And I acknowledge sometimes we speak out of privilege because some people cannot afford it, like, but then it is affordable, quote and unquote, protection for most people. Uh, or let's say for people, it's good for you to explore and look at. There are different premiums which you would look for, which ones you can afford, and you can also ask for the vulnerable fund and all that. So it's affordable protection. Thirdly, the system is improving. So um, we have to be gracious and also look at how there's no perfect system in the world, even in the best of places. Every system has its trade-offs. So the system is improving. We're moving from NHIS now to NHIA, and NHIA is trying to bring like private players, is trying to force standards. So it's not perfect yet, but it's better than being uninsured, definitely. So you don't want to be just one sickness away from poverty. So
Thank you for sharing those three facts with us, Dr. Sumayya. Especially the last point, Nigerians should have more belief in the system and be optimistic to get the best results from the health system. There is no perfect place, like you said, in global north and global south. Actually, I believe during the COVID-19 pandemic, that was what exposed the health systems across the globe from the richest to the most standard. You find out that everybody was struggling. So we are all trying to balance the health system in every country. And I believe with NHIA on board, we'll have better results for Nigerians. Um, from the paper, Dr. Sumayya, can you please shed more light on this sentence? Fatalistic beliefs impaired quality healthcare in Nigeria. What were you trying to say?
okay, so first of all, what's fatalism? So fatalism is just an idea that health outcomes are determined by faith or God's will. So why bother seeking medical care early? So I think my first statement would be Nigerians were very religious people, which is a good thing. It's not a bad thing, but we're very, very religious, and we tend to hear things like, if it's my time, it's my time. If so, of diseases like cancer. At some point, I think I grew up hearing things like cancer. They'll say it's spiritual attacks and epilepsy and all that. So these were
Yeah,
very
exactly.
common things. They were not out of a place for us to. They were not. We tend to shift. I'm from the north, so a lot of epilepsy and all would be like it's gene. That's like a lot of supernatural powers sometimes, and then going for screening is likely inviting trouble. We have that belief, and in as much as beliefs are good, we we are together with like our cultural, our religious beliefs. We can't separate the two. But then these beliefs that sometimes it makes people to delay care. So by the time they reach the hospital, it may be too late. Take, for example, things like cervical cancer screening, which early detection saves lives. I think we cannot overemphasize that. But many women never go for screening because they believe that prevention cannot change their destiny. Like, no, a lot of times, like I'm a Muslim, so another thing when people just see things like it's God's will, but then as Muslims, we know that our bodies are amana. That's
Find
amana
your camel, then the
is
rest
a
to
yes,
God.
it's a trust. So God has entrusted. So that still shifts that concept of we don't take care of our bodies because whatever will happen will happen. And we're very quick to, God forbid, it's not my portion. So then if it's not your portion, whose portion is it? So and it's just that concept of you're shifting. We need a shift because faith and medicine are not enemies. They can actually two truths can coexist, and I'm sure both the main, like Muslims and Christians, we all believe that God helps those who help themselves. So another thing
Yeah.
is health education campaigns, especially taking it down to meeting people where they are at, meeting them at their religious places, and also acknowledging that religious leaders are health stakeholders because they are, because people actually trust their religious leaders more than they trust you sometimes as a doctor. So that's why a lot of times you do a cesarean section, or you do a surgery, a life-changing surgery, and then the next moment they're going to go and do testimony and thanking their religious leaders for. So we will have to like work hand in hand, and that's just the whole concept of fatalism. So because the more we have that mindset shift, the better health outcomes we would have.
Thank you so much, Dr. Sumaya, for emphasizing that faith and medicine are not enemies. We can work together. And also, time will tell if medicine, where we are and where we are going to with integration of religious leaders. Actually, I came across a lecture this morning where a religious leader I don't want to mention was talking about mixing, and I feel this is one of the problems we have. We say we're a very religious country. Mixing, it talked about mixing. I know some people might come for me. Talked about mixing black seed oil with camel urine. That when you mix it together, if the doctor say you have any infection, you take it, go back to him, they won't find any infection in your blood system, something like that. And now you're talking about that fatalism made me remember the lecture I listened to. So basically, where we are and where we are going to as a country, we need, that's what we call stakeholder collaboration. We need to collaborate together and keep emphasizing that medicine is not an enemy to faith and faith is not an enemy to medicine. Lastly, Dr. Sumayya, there is belief among Nigerians that those under NHIS receive poor medical management when they are sick. What is your perspective on this? Because I also work in a hospital and you find people saying that, oh, because we are this NHIS, what are they calling? We're not receiving the best. Look at these people that come to pay their money. You give them, you understand, as if there are even specific drugs for NHIS patients. What do you have to say about this?
So I think this is a very common complaint. So we look at NHIS patients as second-class citizens of the hospital sometimes. So, and I think here's what happens, and this is my opinion from my work as some hospitals may prioritize like cash paying patients because reimbursements from NHIS can be delayed. So
Money is the boss.
exactly. So, and others may cut corners to save costs. That creates that perception of poor management. But the truth is, NHIA, NHIS sets their own service standards to the level of compliance. That is a story for another day. But then there is like a level of service standards that are set, and hospitals are required to treat all patients equally, definitely. So if people should face, I think in all NHIS centers in the hospitals, there is the complaint box. In my hospital where I used to work, it was they used to come and NHIS staff to come and take the complaints of the patients. So they should encourage patients to report it if they feel in any way discriminated against or and all. But I think the bigger issue is like systemic capacity. So when hospitals are overcrowded and under-resourced, everyone suffers. So whether it's the NHIS and the non-NHIS patients alike, they all suffer. It's just that that's when some hospitals, maybe private hospitals, I'm not putting anyone, but then it's like revenue has to be made. So people now prioritize. So I think the most important thing is for NHIA to strengthen, like they should strengthen their monitoring of the hospitals. And also they should penalize like facilities that treat the NHIS patients poorly. So that is where the feedback loop is very important. Hear from like people that are using your premiums and all that. Another thing is to allow patients to switch providers if they feel dissatisfied. It's just like, let me give you an example now. It's using the phone networks. So if MTN gives you poor service, you move to Airtel. The same principle should apply to healthcare. So patients are given choices, and that will drive competition and quality because You don't want to literally just lose your enrollees because you're not giving them quality of care. So I
Thank you
think
so
it's
much.
just a common, yes. And then it also depends on the premiums because I've also seen in a hospital where I've worked where the NHIS staff get better treatment than this. So it depends on your premium, which actually it's wrong. It is wrong. So every patient should be treated alike.
Okay, thank you. Premium, you mean hospital, right?
Yes.
Okay, because I'm trying. You know, we have other people who are not medics listening. They will like, what is premium? Is that money? Is that type of money they pay? Additional money?
So maybe
Okay,
the HMOs they're also using, and also the premiums you're paying. That's just like your subscription, how much you're paying, the bigger
Mhm.
yes. So it still boils down to money for some people, which it's not supposed to be that.
Thank you so much for the excellent explanation, Dr. Sumayya. We've come to the end of this discussion. Do you have any closing statement for our viewers and listeners on NHIS? Like you've simplified everything, and I feel if they read the paper, they will see how very, very simplified it is. That was so hard for me. If you know me, you know it's easy for me to get questions. That it was so hard for me to get questions. What's your closing statement to our listeners and viewers?
Yeah. So I think for everyone is health insurance is not a luxury. So it can actually shield you like from financial ruins and for Nigeria to progress and for all of us to we have to like embrace change. Sometimes we leave what we think is our comfort zone. And another thing is to also demand accountability. If you feel you're not getting what you're paying for or what you're expected, ask for accountability and also for us to change our mindsets. We have to grow in trusts and trust the system. So, and I hope everyone that is watching this, ask yourself, do I or my family have health insurance? If not, what steps am I going to take to get protected? Because I don't want to be one sickness away from financial ruins, basically. So thank you for having me and thank you for listening. And I hope we'll get to a point where at least we'll have 70% of Nigerians enrolled in NHIA now.
Thank you so much, Dr. Sumayya. You moved from 30% to 70%. I see you are very
Yeah.
optimistic about this
It's good to be
system.
overzealous at times.
So, our beautiful audience, is great to see that with NHIS now being moved to NHIA, we are optimistic that Nigerians will have better health system, and with better health system, we are optimistic that there will be reduced mobility and mortality. This is I've not gone through the whole research profile of Dr. Sumayya, but this is one paper that I really enjoyed when I was reading it. Maybe because I have a first-hand experience as well as an enrollee under NHIS. But if you're interested in reading the paper, it's very simple, and I am emphasizing it's very, very easy to understand. Although it's lengthy, but it's very easy to understand. Thank you so much, Dr. Sumayya, for spending your time with us, for sharing your knowledge with us. It's so much appreciated.
Thank
Have
you
a
so much.
blessed week.
Yeah, you
have
too.
okay, have a blessed week, everyone.
You too. Bye.